Right, so in the session today, we are going to look at how we as nurses can support our patients when it comes to nutrition. Both tempting our patients and making sure we're feeding them the right amount, but also talking about the feeding tubes that we can use in practice and how we as nurses can be placing and doing more with those tubes. So we are going to talk about how we can perform nutritional assessments for our patients and work out exactly how much they should be eating. How to tempt patients the right way without risking things like food aversion, which we commonly can see, especially with cats, and also how we place and manage nasoesophageal tubes, nasogastric tubes, and esophagostomy tubes. And we'll also look at some of the more advanced options for providing nutrition to our patients, such as gastrostomy tubes, and a little bit on parenteral nutrition as well. I have also created a couple of handouts for you, which are just at the front here. If you haven't got one already, please help yourself to one in the break. Feel free to take them away, put them up in your practice. They are guides on things like calculating RERs, feeding plans for our patients, and also guidance on how to place and maintain the common types of feeding tubes that we use in practice. So do grab yourself a copy of one of those. If you do want to take pictures of any of the slides or anything at any point, please feel free, although this is going to be recorded for anyone who wants to, reflect on anything again in the future. So when we start talking about nutrition, we firstly need to talk about malnutrition, because that's what we're aiming to avoid in all of our patients when it comes... Okay, what are we checking out? So we need to avoid malnutrition in our patients. So malnutrition is defined as a state where an animal's diet is either inadequate or unbalanced, and that inadequacy or imbalance is leading to health problems. Now that technically includes dietary excess as well as dietary deficiencies. However, it's deficiencies that we're going to be talking about today. So patients that are at the highest risk of developing malnutrition are those with any kind of chronic disease that impacts either the absorption or intake of food, patients with prolonged hospitalisation, those at an increased age, and those who are consuming less than 80% of their resting energy requirement for 3 days. And that risk increases further after 5 days. So actually, if we think about the majority of our patients in hospital, quite a lot of them are not eating 80% of their RER for 3 days. And that's only since admission. That's not taking into consideration the time that they've been inappetent or anorexic at home. Patients with weight loss, muscle loss, or a body condition score of less than 4 out of 9 are also at increased risk, as are patients with low albumin levels, sepsis, or things like significant wounds or burns where these patients are going to lose more protein. Patients with any illness longer than 3 days are also at risk of malnutrition, and actually that's the vast majority of our inpatients. So this is a big problem for us to deal with. When our patients stop eating, quite a few things happen as a result. Firstly, they will start looking for alternative sources of energy, and this is going to mean breaking down their lean body mass, so their muscle. So they're going to start catabolizing muscle and losing that to try and get things like protein. Their immune system will also become affected, so these patients will get immune dysfunction, which predisposes them to infection. They also have impaired wound healing and impaired muscle strength. And unsurprisingly, in our inpatients with an inadequate energy intake, there is a greater risk of death. And that's, not going to be, we're not saying that every single patient that's inappetent is going to die, but there are studies that show that patients that are in poorer nutritional health do have a greater risk of death. So for our patients, they're going to be in hospital longer if they're not eating enough. They're going to take longer to recover from their illness, injury, surgery, whatever. And the longer they're in hospital with a impaired immune system, the higher the risk of things like hospital-acquired infections. So catheter-associated infections, feeding tube infections, surgical site infections, all of those are going to be a greater risk. So we know that addressing malnutrition is really important, and in order to do that, the first thing we need to know is how much should our patient actually be eating? Because until we know that, half a sachet of sensitivity control twice a day, if they're eating that, fine. But if we don't know what their RER is and we have no idea how many calories they should be consuming, we have no way of quantifying if that is going to be enough for them. So why do we do this? Firstly, because providing enteral nutrition early is really, really important. We know that patients who are critically unwell, cahexic, so have increased energy expenditure, patients who have a vast majority of medical conditions or present as emergencies often are at increased risk of malnutrition, and getting nutrition into these patients early is absolutely essential. In fact, cats, hyperexia is the third most common reason a cat will present to the clinic. That was shown in the new ISFM guidance on managing inappetence in cats. And in one study in the States that was performed last year, they found that 84% of dogs hospitalised in a referral centre were eating less than 25% of their resting energy requirement. So this is a big problem that we deal with in referral and in general practice. But in order for us to support our patients, as we said, firstly, we need to know how much they are eating or how much they should be eating, so that we've got some evidence behind us to intervene. So this really means calculating their resting energy requirement. The resting energy requirement is the amount of calories our patient needs per day to maintain homeostasis, so to maintain all their normal body processes at a state of rest. And whilst no one formula is the perfect fit for every single patient there is, this is really our best starting point. There are two different ways that we can calculate this. We've got the linear formula, which might be the one that you're more familiar with in practice. So this is 30 multiplied by the body weight plus 70. And this is okay to use. It's generally a little bit less accurate in very small or very large patients. It tends to overestimate calories very slightly. There's also this one, which we're generally tending to use more often now, which is the allometric formula. And this is body weight to the power of 0.75 times 70. And all of these calculations are on the little handouts as well. This one I like because it's suitable for all patients, regardless of their size. And so if you only want to remember one calculation, this is the one to remember. And although to the power of likes to complicate things a little bit, you can do that quite easily on your smartphone on Scientific Calculator. So you will find a little button that says x to the power of y. That's the one that you want to use. So you type in the weight, hit that, type in 0.75 and multiply that by 70, and that will get you your patient's resting energy requirement. Now, I must stress that we want to be doing this on the weight that the patient comes into us with, not a previous weight from before they were ill, not their ideal weight, anything like that. So when a patient is in hospital, anorexic or hyperexic, our goal is to keep things stable. It's not to get that patient gaining weight in hospital, and it's not to get that patient losing weight in hospital. In the clinic, we want to keep everything static. We want to avoid further weight loss, but avoid significant weight gain, because that risks complications. So we can see things like refeeding syndrome, which is a response to a patient who's been anorexic for some time being overfed more than their body can cope with. And so really our goal is just to keep their calorie intake stable for where they're currently at. And then when they're better, when they're over their acute period of illness, then we will make a long-term plan for getting them back up to their normal or healthy body weight. We also have maintenance energy requirements. Now, we don't tend to use these as much in practice, but we do know that in some cases, RER is not going to be sufficient. Now, traditionally, we used to use illness factors for our unwell patients. So we used to say if this patient is in for cage rest, they would have 1.2 times their RER. If they're pregnant, we're going to do 2 times their RER, etc., etc. We now know that illness factors, where we're basically putting patients in a box correlating to their condition, aren't appropriate. They risk overfeeding. So instead, for those patients, we're going to use their RER. We're going to monitor their response to feeding and tweak things as needed on an individual basis. Life stage factors, though, we do use. So we know that certain patients, such as puppies, kittens, pregnant animals, lactating animals, will have higher energy needs. And so for those patients, it is appropriate to use a maintenance energy requirement. So this is where we're going to take, for example, puppies who are up to 16 weeks of age, we use 3 times RER. Kittens, generally it's around 2.5 times, that sort of thing. So those certain categories of patients, we will give them higher energy needs, but for your general adult unwell patients in the hospital, it's the RER alone that we want to be working from as a baseline. The other thing to mention is this is not just for patients that have a feeding tube put in. So quite often we'll place a feeding tube and we'll say, yep, we need to do them a feeding plan. And yeah, we absolutely do, but actually, if we did that feeding plan before the patient had a feeding tube, maybe we could have highlighted anorexia earlier and popped a feeding tube in a little bit sooner. So really, we want to be creating feeding plans for all of our inpatients, not just those needing tubes. We know that most patients don't tend to have their exact feeding needs calculated in the hospital. And in fact, in that same study that found that most dogs ate less than 25% of their RER, they found in their investigation in a referral centre that only 18% of patients had feeding instructions that were clear and able to be followed on their hospitalisation sheets. The patients, that 18% that did have things calculated out properly, were 10 times more likely to have their calorie intake recorded, and they had feeding tubes placed much sooner than patients that didn't have their calories calculated. Median was day 2 of hospitalisation. So we know that actually by having this information, it helps us make better decisions more quickly for our patients. So the take home, every single inpatient should have their energy needs calculated and the percentage of those needs that they're eating recorded every single day, regardless of whether there's a tube in place or not. And this is not something that you need to be an MRCVS to do. There is no reason why we as nurses can't be doing this off of our own back, using our nursing intuition and autonomy, and then taking that information to our vets and saying, hey, my patient has eaten 25% of their RER for the last 2 days, please can I place a nasoesophageal tube? Because we can do that. So let's put this into practice. This is Bertie. Bertie came in a little while ago to our medicine service. He's an 8-year-old male neutered domestic short hair, and he had a working diagnosis of triaditis. So Bertie currently weighs 4.2 kilos. He's usually around 4.85, and he's been anorexic for the last 5 days. So we've popped a feeding tube in, as you can see. He's getting a tube feed here, but we're going to make a plan for him. So the first thing that we're going to do is calculate Bertie's RER. So we're going to do this using our allometric formula. And if we do that with his current weight of 4.2 kilos, it works out at 216 calories per day. We're then going to convert that to a feeding plan. We're going to use Royal Canin Recovery for him. And that has an energy density of 1 calorie per mil, which makes our maths really easy, which is great because no one wants to do maths at 9:30 in the morning. So his energy needs, his feeding needs per day are again 216 mils. We're going to build up to this gradually because we know that he's been anorexic for 5 days. And so if we go straight in at 100% RER, especially given that he's got triaditis, we're likely to cause some problems, and he's going to be at risk of things like refeeding syndrome. So as a general rule, I like to take the number of days that they've been completely anorexic for and take that many days to get them up to 100%. So if they've been anorexic for 3 days, start at a third. If they've been anorexic for 5 days, start at a fifth. If they've been anorexic for 4 days, start at a quarter. And that way, you're kind of tailoring it to the individual patient rather than just sticking to a 1/3, 2/3, 3/3 rule, because that might not be suitable for all of our patients. So if we start at a fifth of this, we're going to start him, there we go. Let's start him at 20% RER. That works out at 43 mils on day 1, and then 86 on day 2, etc., all the way up to his full 216 on day 5. Then we're going to turn that into a feeding plan looking at the number of feeds and the size of the feeds per day. So ideally, we would feed our patients every 4 to 6 hours in hospital because gastric emptying time is around 4 to 6 hours in most patients. And we try where we can to avoid the meal size exceeding 10 mils per kilo because that is ideal gastric capacity for a patient that has been anorexic. So for him, on the first day, we can do his 43 mils divided by 4, gives him 11 mils thereabouts every 6 hours. And that would be fine for him. And then we will increase that each day until he's reaching his full RER intake. And that's really how we're going to approach these patients. Now, yes, this is via a feeding tube, but actually if we were offering him food, which we will be, we would do this the exact same way. And then depending on how much he was eating, we would just top him up with a tube feed if he hadn't eaten enough to meet his calorie needs on his own. And that's really how we want to be approaching nutrition in our patients. So now we've calculated our energy needs, we've created a feeding plan, and we know how much our patient should be eating, we need to make that happen. And there's really 2 ways that we're going to go about doing this. We've got tempting our patient to eat, and we've got placing and using a feeding tube. So starting with tempting, this is going to be generally what we're doing for our hyporexic patients rather than our anorexic patients, or whilst we're trying to convince our vets to let us pop a feeding tube in perhaps. So this is going to be things like trying different diets, bearing in mind which diets we're trying. So no prescription diets or long-term diets that we want that patient to stay on past hospitalisation should be introduced in the hospital. The reason for that, especially with cats, we're likely to get food aversion, so we don't want that patient associating that food with that period of illness or hospitalisation, because that's going to stop them from eating it. Familiar foods, if possible, familiar consistencies, familiar brands, familiar flavours, and preferred or treat type foods, ensuring that they are, where possible, nutritionally complete and balanced. We also need to look at feeding behaviour. So we're going to talk about underlying causes in a second, but any underlying causes driving a patient's inappetence need to be addressed before we try and feed them and before we give them any appetite stimulants. If you're at hospital feeling really ill and someone gives you a McDonald's, it doesn't matter how amazing that McDonald's might taste, the last thing you're going to want to do is eat it when you're feeling sick. So we definitely want to address those underlying causes first. Also, avoid feeding your patient at the same time as things like medications, examinations, or treatments. Anything that could cause them stress, we don't want to be doing at the same time as feeding them. We want them to make sure they feel safe in their environment when being fed. That might mean having them be a bit of a secret eater, where we only feed them at times where the ward is quiet and we're making the area as nice and as optimised as possible for that patient. It might mean taking them out to a consult room, perhaps, when there's a little lull in between appointments where time allows, and giving them some time to stretch their legs, some grooming, some TLC when we're trying to get them to eat. It all depends on the individual patient. We also want to not overwhelm them with food choices, especially cats, avoiding things like the double diner bowls or giving them a smorgasbord of lots of different things all in the same bowl, because that again is likely to overwhelm them and perhaps put them off of eating. Now, we mentioned those underlying causes. The big 3 really are going to be pain, nausea, and stress. So making sure, if there's a chance your patients could be painful, that we have trialled analgesia or reviewed to make sure that the analgesia that they're on is appropriate. Making sure we've trialled antiemetics where appropriate, so trialling Inappetent, for example, perhaps, or if a patient is already on Inappetent and you think they're still nauseous, perhaps adding something like ondansetron on top, if the vet, of course, agrees. And then stress, so looking at environmental adaptations that we can make, but also using things like anxiolytics, so like gabapentin or trazodone, for example, where needed in really, really stressed patients. And then, after we've done all of those things, that would be the time to think about appetite stimulants. So we've got metazapine for cats, which I'd imagine most people are using. Yeah. And then we've got caprimorelin, which is Entice, that we can use for dogs and also for cats as well. Anyone using that? Some nods, some shakes. Cool, perfect. And then we've got that one, which I feel like probably quite a lot of us use perhaps a bit too much. We hope that all of those things are going to be enough to get our patient to eat. And then, we do that for a couple of days and they're eating some amount, but perhaps not quite enough. But we hope that that will improve over time. But that's really when we want to be getting into this category. And really, with feeding tubes, the three main ones that we place are either nasoesophageal or nasogastric tubes or esophagostomy tubes. And the indications for each of those tubes is going to vary, and our role as nurses in placing and managing these tubes varies too. So let's start by looking at nasoesophageal tubes. These tubes are ideal for in-hospital, short to medium-term nutritional support. They can be placed consciously in some cases or under light sedation. Pro tip really would be try and keep your sedation as light as possible if you are placing these tubes under sedation, just because the deeper sedated a patient will be, the more likely it is that your tube's going to end up in the wrong place. You ideally want them to still be able to swallow that tube, otherwise there's a higher chance that it will end up in the airway. Now these tubes, because they go through the nose, are narrow bore, which means that they're only going to be suitable for liquid diets and liquid medications. If we crush up tablets and pop those through one of these tubes, we're going to block it. And that can happen all too easily. And there's nothing worse than having a tube in a patient and then it blocking and you just can't use it and have to take it out again. It's absolutely heartbreaking. These are not suitable for at-home use. There's too high a risk of these moving for us to safely send a patient home with one of these in. If you need to send a patient home with a tube in for carers to use at home, use an esophagostomy tube. And perhaps most importantly, we can put these in under Schedule 3. So actually your vets don't even need to do this, they can get you doing it for them. Then we've got nasogastric tubes. Nasogastric tubes are placed in exactly the same way and have pretty much all of the same considerations, except for the fact that because they end in the stomach, we can use them to empty the stomach. So this is really, really helpful for dogs with ileus, where we've got low GI motility and we've got content accumulating in the stomach, and cats with ileus, although we see that perhaps less often, and also for parvovirus as well, because all that horrible content that these puppies are vomiting, sitting in that stomach, we can get rid of for them. Now when we do this, we have to be careful, because if we remove too much, we can cause changes with the patient's electrolytes and acid-base levels because we're removing things like hydrogen and chloride. But for some cases, it's really, really useful. So this is the patient that actually our medicine team popped a tube in on Thursday. This was a last-minute addition to my slides after this case came in. This is a patient who has pancreatitis, a spaniel with pancreatitis. We placed a nasogastric tube. We checked it on the X-ray. As you can see here, it's happily in the stomach. And one of the reasons it's so easy to tell that is because this stomach is really full of stuff, which is going to be making this patient really uncomfortable. And he had really quite severe abdominal distension. His stomach felt really hard. He was really uncomfortable. We drained about 500 mils of air and fluid from the stomach. And we could see immediately after that he was looking much better. His abdomen was a lot less distended and he was much more comfortable. Now, I'll tell you, it was 2 nurses that put this tube in. It was 2 nurses that x-rayed this dog, and it was 2 nurses that looked at that x-ray and went, that stomach's really, really full, we're going to drain that. And we drained it, and then we sent the clinician this x-ray and said, we fixed your dog for you. So we can do a lot more with these patients, really, than perhaps we get the opportunity to as nurses. So gastric emptying as well as feeding, plus all of the other same considerations as our nasoesophageal tubes for our NG tubes in practice. And then we've got our O tubes. This is perhaps the one we use most commonly, would you say? Is this the one you're tending to use most in practice? Yep. So medium to long-term feeding, you can keep these in for months with good maintenance. And the main benefit of that is that we can send our patients home with these in for carers to use at home, not just for food, but also for things like medication and enteral water where that's needed as well. So I took my kidney disease cat home with an O tube in so that I could hydrate him, as well as give him his food and medications. Carers that really, really struggle to medicate cats, I say cats particularly just because they are generally the most challenging ones, these tubes can be a really great option for those people as well, where the cats are on lots of different medications. So not just for feeding. Because they are wider bore tubes, they're suitable for more dense diets, so blended wet foods, for example, or soaked and blended biscuit foods, and crushed tablet medications. They do require a brief anaesthetic to place, so they may not be suitable in all patients if we've got a really, really unstable patient. But chances are, if your patient is not stable enough to be anaesthetised for an O-tube, they're probably not stable enough to receive nutrition at that moment in time. And they will probably let you place an NO or NG tube consciously if you need to. And legally, we can't place these tubes unattended as veterinary nurses under Schedule 3, but we can assist the vet with placement. So you can be helping to do this. You can either be the person in sterile gloves making the incision and doing the suturing, or you can be the person putting the forceps into the patient's mouth, grabbing the tube and turning it and popping it back down the esophagus. So we can help with placing these, and of course we're going to be managing them after placement. And there are instructions on placing these in the guidance if anyone wants to grab one. Now there are also going to be some contraindications and considerations for each of these tubes, because not every type of tube is going to be suitable for every type of patient. So nasal tubes, we really want to be avoiding these in patients that have facial trauma or disease, nasal disease, cat flu, bleeding risks, that sort of thing. We also want to be avoiding these in patients with uncontrolled vomiting. Now, does that mean that you can't ever put one of these in a patient that presents with vomiting? No, we often do. But what it means is that vomiting needs to be appropriately controlled with antiemetics so that that patient is not going to vomit up that tube and have that move. Also, increased intracranial pressure. We don't want to be placing these tubes in. If we get these patients like sneezing, that's going to increase that intracranial pressure further. So head trauma cases, patients with potentially intracranial neoplasia, that sort of thing, we really want to be avoiding these types of tubes in those patients. Then our O-tubes, patients with esophageal disease, so esophagitis, esophageal strictures, that sort of thing, we don't want to be placing these tubes if at all possible. Patients who are unstable for GA, as we've already mentioned, patients with bleeding disorders, and again, patients with uncontrolled vomiting, we need to be careful as well. Because these tubes are sutured into the neck, there is less chance of them moving. However, a patient with vomiting with a tube in their esophagus could still potentially vomit that tube up. So we need to make sure that that vomiting is controlled with antiemetics. So we've placed our tube, either a nasal tube or an O-tube, depending on our patient, and now we need to think about managing it. So nasal tubes, as we've mentioned, have the highest risk of movement or dislodgement. So this means we need to be checking these really, really carefully before use, making sure we're happy with their position, especially in patients that have vomiting or regurgitation. If there's any concerns that your tube might not be in the right place, don't use it and take an X-ray. That's the best way that we can document that we're happy and that nothing's moved. With nasogastric tubes, ideally aspirate them before you feed so that you can check how much volume is sitting in the stomach, because if there's lots of content in there already, that might mean that it's not appropriate to feed that patient right now. It might mean that we need to give them less food, or it might mean that the vet needs to review the medication and maybe add in something like metoclopramide if the GI motility is slow. If we're happy with how the tube is placed and we're ready to give our feed, flush the tube before use, ideally with sterile water if possible for a nasal, just because there is always a chance it could move. And then once you've fed and you've given, whatever you need to give, be that liquid medication, whatever, you can then flush afterwards with a bit of lukewarm tap water. And then there's not a surgical site or anything here to worry about, so there's not huge amounts of site care that needs to be performed. But it is good practice to just check the nose regularly for things like crusting or discharge and clean as needed, especially because we're blocking airflow in one nostril for these patients. So if there is a lot of gunk, crusting and things on the other side, it's going to be even more uncomfortable for them. They're going to feel very congested. Then we've got our O-tubes. So we're going to check and clean the site twice a day in hospital. If we're sending patients home with these in, then we would advise our carers to do this once a day at home. And when we're checking the site, I'm looking at the suture integrity. So am I happy that my finger trap suture is still nice and tight? My tube's not moving. Sometimes with tubes that have been in for a long time, the stitch will start to kind of come out of the skin, it'll pull through. And so what we want to be doing is, if we're worried that could happen, intervening at an early stage, resuturing, whatever that looks like, to make sure that we don't lose that feeding tube. We also want to look for signs of infection or inflammation or reaction and assess how comfortable our patient is with that tube in place. Looking for things like retching or gagging when it's handled. Sometimes they'll be kind of doing exaggerated swallowing or stretching the neck, and that can just indicate that they're actually not finding the placement of that tube very comfortable. If you're concerned, based on your examination of the tube, before you clean it, what we would do is take a swab for culture if there's signs of infection, because actually you can take it, and then if the vet says they don't need to send it, you can just chuck that swab in the bin, so that's fine. Also, use a clean cotton bud and take a sample of the site, roll that cotton bud on a microscope slide, and you or the vet can then have a look at it under the microscope and check for signs of infection. And that might give them guidance on whether they send that culture swab off or not. Once you've done that, then, we've taken our sample. We're not going to go and leave the patient and look at it under the microscope, obviously. Once we've checked the site and we're happy and we've collected our samples, then give it a clean and then redress it. And then we're going to check the tube and flush it before and after each feed. So those are the most common tubes that we place in practice. They're not the only tubes we place in practice, though. So we also place gastrostomy tubes relatively commonly in some of our medical patients. And this is usually patients that have esophageal disease. So they've had an esophageal foreign body, for example, or they've had really horrible esophagitis, or esophageal strictures where there's a narrowing inside the esophagus. For these patients, feeding through the esophagus is not always appropriate. And so in these patients, oftentimes we will need to feed directly into the stomach through a gastrostomy tube. Now these can either be placed surgically, which is a G tube, a gastrostomy tube as Nala is demonstrating here, or placed endoscopically, which is what we're doing in this picture here for Monty. And this is Monty's peg tube sitting inside his stomach. Now these are used for long-term nutritional support. We're talking months to years. And in fact, in these patients, it's really, really important, because they're designed for long-term support and because of how they're placed through the body wall directly into the stomach, that we wait for 24 hours after placing them before we use them, and we don't remove them within the first 14 days after placement. Because there's a risk of peritonitis with these tubes, because we are placing these through the body wall into the stomach, we need enough time for a seal to form before we feed and also before we remove the tube. There are some cases where we can't use the stomach at all for feeding, and that's where we have to think about post-pyloric feeding. So if a patient has really awful gastric disease like gastric neoplasia, for example, or severe gastric ulceration, we might not be able to feed into the stomach at all. And if we need to do this, we've got a couple of options. Firstly, we can place a jejunostomy tube or a J tube. This is the only J tube I've ever seen in my career, so I had to take a picture of it, obviously, because I don't think I'm ever going to see another one. And the reason that I don't think I'm ever going to see another one is because in an ideal world, we wouldn't use these. The reason for that is because they feed, as the name suggests, into the jejunum, so into the middle third of the small intestine. And most digestion and absorption happens above the jejunum. So actually we are missing quite a lot of opportunity for our patients to get the nutrition out of their food by feeding them into this region of the GI tract. So for that reason, quite a lot of the time, if you do use these tubes, patients will have things like ongoing diarrhea because they can't actually digest that food normally. Also, when we feed directly into the small intestine, the intestine, unlike the stomach, it can't stretch, it can't accumulate big boluses of food. So these patients need to have CRI feeding with a liquid diet delivered as a trickle, over 24 hours via a syringe driver. So it's very, very technically challenging to do. What we tend to do more commonly is give parenteral nutrition. So this is an intravenous source of calories for our patient, made up of amino acids, glucose, lipids, and electrolytes. You may not be able to see from the picture on the screen, but what we've got here is a bag divided into 3 sections. So we've got a lipid section here, which probably looks familiar, and that's because it's basically intralipid. We've got a middle section, which is glucose, concentrated glucose, and then the outer section here, which is kind of L-shaped, is a amino acid and electrolyte solution. And what we're going to do is we roll the bag and mix those three compartments together, which is the most satisfying thing in the world, let me tell you, it really is. And then we administer that mixed solution to our patients. So when we do this, we give this as either the patient's whole source of calories, which is TPN, total parenteral nutrition, or as a partial source of their calories if they can tolerate some food via the GI tract. And that's partial parenteral nutrition, or PPN. Now, parenteral nutrition is reserved really only for patients that can't tolerate food via the GI tract. And that's not a patient that won't eat, that is a patient that's GI tract is not working, so they can't absorb nutrition sufficiently from their food. So this is going to be things like septic abdomen patients that have had an enterectomy for a foreign body, for example, or really horrible parvo cases, or really horrible pancreatitis cases, or patients with such severe malabsorptive disease that the GI tract just can't absorb the nutrition that it needs from the food. It's not without risk. There are quite significant risks to be considerate of with parenteral nutrition. The enterocytes, which are the cells that line our intestine, get their nutrition from the food that directly passes over them. So if we are feeding parenterally into the veins and we are not getting anything to those enterocytes, they are deprived of nourishment. And as a result of that, they become less good at their job. And their job is to basically keep the bacteria that's inside the gut, in the gut and out of the body, out of the bloodstream. So if we aren't feeding the gut, we can get what we call bacterial translocation, which is where the bacteria in our normal GI flora in our intestines start to make their way places that they shouldn't and cause problems. So wherever possible, what we want to be doing is giving something to the gut, even if that is a trickle feed via a nasogastric tube at 1 ml an hour, because our goal is not necessarily to get calories to the patient with that food, it is to get nutrition to the gut and keep it safe, protect its barrier ability. And then we're going to get calories into the patient with our parenteral nutrition solution. So wherever possible, we're going to give this alongside enteral feeding in some way. Okay, so I'm popping the bag. As you can see, it is genuinely the most satisfying thing in the world to do ever. And then when it finishes buffering, what you're then going to see me do is mix it together. And then I'm going to put some sterile gloves on and aseptically connect my giving set, a lipid filter which catches lipid clumps, and an extension set together. And it's really important that you do all of this aseptically. So I'm setting it all out on a sterile drape, as you can see, and connecting everything all aseptically. Really important, because these bags of food are not just food for our patients, they make great food for bacteria as well. They also don't contain any preservative, so it's really important to do everything aseptically. So as you can see, once I've mixed all the compartments together, it's all gone like a uniformly milky colour, and it's now just going to run through the extension set, the lipid filter, and then also the rest of the extension. And once that's all primed and ready, that will then aseptically be connected to the patient. So what you won't see in the video here is another one of our nurses who has the patient and is going to open up the clamp on the central line and everything for me, because we have to give this via a central venous catheter in the jugular vein. And I, whilst staying sterile, am going to attach everything to the patient, and then I'm going to attach my giving set into a fluid pump and give this intravenously. And the way that we calculate this is kind of like a combination of a fluid calculation and an RER calculation. So we calculate the patient's RER, we work out the percentage of that we want to give via parenteral nutrition, and we divide that by the energy density of this, which it will say on the bag. And then you divide that by 24, and that gives you your mil per hour drip rate to put into your infusion pump. Now, depending on how many other things your patient is on intravenously, you might need to also decrease their other fluid rates by that amount so that we're not overloading them. but we're going to give this as an IV source of both fluid and calories. So I wanted to finish off with a few examples. I told you there'd be participation. I promise it's not too bad. So what I'm going to do is introduce you to a few cases and ask you to shout out whatever you think is going to be the most appropriate way that we're going to feed this patient. So patient number 1 is Pikachu. Look at Pikachu, very, 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 very cute. Pikachu is a 12-week-old female entire Daxi who came in to see us with HGE and regurgitation. Weight on admission was 1.2 kilos. She'd been anorexic for 2 days. If you were going to place a feeding tube in Pikachu, which one would you go for? NG. NG, yeah? Yeah, exactly. Because we're going to want to aspirate all of the stuff in this dog's stomach. Probably because of that, mostly. The fact that if any patient comes in and regurgitation is in their history, I'm automatically thinking this patient probably needs an NG tube if we're placing a tube, because it gives us the option to drain content from the stomach as well as use it for feeding. Now, Pikachu might end up needing some parenteral nutrition as well, but hopefully not. And even if she does need some parenteral nutrition, the fact that we've got that NG tube in place means that we can give something enterally alongside that to feed the gut. Next up, this is Layla. Layla at presentation was 6 years. She's definitely a lot older than that now. She came into us with severe esophageal strictures after regurgitation under anaesthetic for a TPLO. She weighed 23 kilos as a Labrador. She definitely should have weighed a lot more than that. And she'd been anorexic completely for 3 days at the time that we popped a tube in her. What tube would you place in Layla?
Peg.
Peg, yeah. Yeah, that is exactly what we did. Layla had, I think Layla might still hold the record for, she was a very, very long stay ICU patient, and she had to have a lot of intensive management and peg tube care and feeding. So you can see we're actually using the peg tube in this picture here. So she's actually having some food by mouth at this point because she could have a little bit of very, very, very specific consistency food, whilst also giving water via the peg tube, because she could cope quite well with semi-solid food, but liquid food she would struggle with. So we didn't really give her water orally. Next up, this is Lucy. Unsurprisingly, given how day-glow yellow Lucy is, she has hepatic lipidosis. She's a 12-year-old female knitted Bengal. She came in at 3.2 kilos with a 7-day history of anorexia. What tube would you pop in Lucy? O-tube? Is that O-tube? Great. Yeah, we would do. O-tube is going to be the most appropriate longer-term solution for Lucy. Depending on how stable she is when she comes in, I might put in an NO tube on the day that she comes in, and then replace that with an O-tube when she has an anaesthetic for, say, imaging, FNAs of her liver, that sort of thing. Being that hepatic lipidosis is the disease, nutrition is the cure for hepatic lipidosis because it reverses the lipidosis. So getting food into these patients early, just a tiny amount, because they're really, really high risk of refeeding syndrome, is going to be really important. So O-tube definitely, because she's going to need to go home with this in for her carers to continue feeding her at home. But it may be that we need to think about an NO tube initially so that we can get calories into her ASAP. Last one, this is Akila. Akila is a 1-year-old female neutered Doberman who had an intestinal foreign body, which was removed. She then developed septic peritonitis and severe ileus as a result. She weighed 20 kilos and had been anorexic for 5 days. So how are we going to feed Akila? What are we going to do? Yeah, parenteral nutrition. But what we will probably also do, because of that ileus, is put a nasogastric tube in place, because we can then be emptying any content that's accumulating within the stomach, and then alongside giving her prokinetic drugs like metoclopramide, for example, we can then give her a tiny, tiny, tiny amount of microenteral nutrition. So even something like Oralaid, just something to the gut to feed the enterocytes that line the intestine and protect them and prevent further complications, especially given that she's had septic peritonitis and GI surgery. So GI surgery in itself is not a reason not to give our patients enteral nutrition. In fact, it's arguably even more important that we do where they can tolerate it. So what we're doing here is we're feeding Akila, giving her calories with her parenteral nutrition, but also feeding the gut as well. So that is everything from me this morning. Thank you so much for your attention. Just to sum everything up, malnutrition is, perhaps unsurprisingly, a lot more common than we might think in practice. Remember, third most common reason cats present to the clinic, and 84% of dogs will consume less than 25% of their RER. So this means that for us as nurses, supporting nutrition in our patients is absolutely essential. It starts with performing a thorough assessment, calculating their nutritional needs, and monitoring their response to feeding and adjusting our plan as needed. Any patient that's been anorexic for 3 days or hyperexic for between 3 and 5 days should have a feeding tube placed, selecting the most appropriate one for the individual patient and their disease process. And for us as nurses, we are heavily involved in this process, managing these patients in the hospital, encouraging them to eat, advocating for their needs, asking for feeding tubes, and placing and managing them. So definitely never ever underestimate your role in supporting these patients.